الأسبوع اللي فات ما كان.
ايوه، الكيس بتاعت الاسبوع اللي فات دي اخر كيس تعتبر، مش كده يا موجة؟
لا، في واحد،
في
هم
واحدة
تقريبا الفضلوا يعني كلهم في اوفر دوز، يعني في حاجات مختلفة.
لا ما خلاص، ما دام اوفر دوز ما في داعي نكررها، مش كده؟
أنا أفتكر
الاسبوع
أنا أفتكر محاسن قالت لي كيس بتاعت 21 وكيس بتاعت 10.
10، ايوه.
اوكي، يو كان ستارت. شكرا لكم.
طيب،
هنبتدي أفتكر.
21 هي ما فيها هنا، ما في كتابة في السيميوليشن. ما في كتابة، الحاجات كلها مكتوبة. أنا ما عارفة انتوا المرة اللي فاتت عالجتوها كيف المشكلة دي. لكن 10 فيها، يعني فيها كتابة، فيها يعني ممكن الزول يسأل ويكتب ويجاوب. أنا خشيت
لا
شفتهم.
21 ما فيها كتابة، كيف يعني فيها شنو 21؟
يعني الحاجات قبل كده كان لاقانا كيس زيها لما نخش في البيشن بنلقى انفورميشن في الانفستيجيشن، كل الانفورميشن موجودة يعني. ما في حتة ما في مجال انه نكتب الأسئلة وهو
لا لا لا،
يجاوب.
احنا عايزين، لا عايزين اللي
طيب،
بيسألوا فيها ما هي.
معناه هنعمل 10.
خلاص، اوكي، الميكروفون ليكي وشكرا لكم.
في أعتقد إنه فاطمة والشباب من المرة اللي فاتت برضو ممكن يعملوا، هم عارفين إنهم الكيسز عموما يعني. في assignment يتعمل عليهم.
الناس اللي عليهم الأسايمنت موجودين ليتن.
لا، أشوف اسمهم. أنا عارفة فاطمة بس، لكن البقية أشوفهم بس.
يعني احنا علينا كان الكيس بتاعت الأسبوع اللي فات.
أيوة، خلف الله ولا منو؟
أنا يا دكتورة مهجة، أنا ما قدمت الأسبوع اللي فات، لكن عندي نية أقدم يعني.
يمكن
ممكن
يا
الناس
نقدم
اخوانا
عادي.
وقلنا زول يا خلف الله،
المسجلين هم.
قدمت قبل كده يا خلف الله؟
دفعوا
يا
طيارة.
خلف الله،
أيوة يا
انت
بوس.
قدمت قبل كده صح؟ قدمت قبل كده.
صح صح
لا
صح.
خلاص، ادي فرصة للناس اللي ما قدموا
الناس
يا خلف الله يا اخي.
خير 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 يا
شكرا
بوس، ما في
لك.
مشكلة.
شكرا.
عارف إنه مشكلة يا بوس.
عندك من انت فاطمة منو؟ ما فاطمات كتار.
فاطمة حسن.
غير منو؟ انتوا كم زول المفروض يقدم الليلة؟
افترض 3 الأسبوع اللي فات وفي 3 الأسبوع ده.
السلام
الاثنين
عليكم.
الباقيين.
عليكم
عليكم
السلام.
السلام.
مفترض نقدم ثلاثة، لأن أنا عمر قاسم ومعي محمد جلال، ومفترض معنا خلف الله.
لا خلف الله، قلنا له
قدم.
ادي فرصة للناس ما قدموا، لأنه قدم قبل كده. ما عايزين زول تو ريبيت البرزنتيشنز عشان الناس كلها تلقى فرصة. خلاص ابتدوا، الناس الموجودين ابتدوا.
اللي هيبتدي يقرا من هنا الكيس انترودكشن هنا ده، عشان هبتدي افتح بعد في البيجينينج. اللي هيبتدي يقرا الكيس انترودكشن الموجود.
هتبدأ أنت يا عمر؟
يلا ابتدي
والله كان
ستارت.
مفترض محمد، لكن ما في مشكلة، ممكن أبدأ، ما في مشكلة.
أوكي، ستارت.
طيب، an 18 years old female presents with altered mental status found by emergency disoriented with focal weakness. Uh, no obvious trauma, feels warm, direct to resuscitation bay. طيب، Tara 20 years old presented with altered mental status found by emergency in her bed without signs of trauma, disoriented, without focal weakness. Her vitals in the field were notable for a respiratory rate of 28. Finger stick blood sugar was 89. On arrival, she is unable to provide any history. Parents are on their way, but stated on scene that she has no history of any medical illness. ما فيها كلام كويس.
دي شكلها كيس ما فيها هنا أسئلة، ما في أسئلة لأي زول. البيشنت
تحتاج stabilization يا أبو صالح.
أوكي، أنت بس وجهني بعدها.
لا stabilization physical stabilization physical.
أيوه
لا physical ما تبعنا. شوف لنا كيس عايزه psychiatric history and mental state examination diagnosis management plan. الفيزيكال stabilization اصلا ما جزء من الكوريكولم بتاعنا. اي بي سي بس الحاجات الرئيسيه، لكن الديتيلز وبتاع دي ما دي تبع ناس الميديسين وناس الاي ار.
اوكي، معنا نشوف الكيس الثاني.
21 ولا دي كانت 21؟
دي كانت 10 اعتقد. 21 معنا، نشوف 21.
ذاتها. الكيس دي برضه أبص unresponsive unconscious.
يا دقيقة.
برضه يا
نفس
اخواننا لو
القصة.
unconscious انت as a psychiatrist you cannot deal with an unconscious patient. نحن لما زمان ينادونا في الليزون سايكايتري سواء كان في الاي ار ولا في الميديكال وورد ولا في الاي سي يو بيقولوا لنا البيشنت از unconscious، طوالي بنكتب لهم please please let us know and call us when the patient is fully conscious. انت as a psychiatrist لو عندك patient في الوورد بتاعك في psychiatric وورد وبيقى unconscious بتحوله لناس الميديسين، اصلا ما شغلك ده.
تمام.
فبالتالي unconscious patient cannot be examined mentally ولا history taken from him or her. فعايزين conscious patient. شوف لنا اي patient تانية في الفول كود ده عشان نخلص الفول كود دي ونمشي للسيم فلو بعد ذاك.
احنا الباقيين اشتغلناهم.
في 135 ما اشتغلناه.
طيب 135. هيجي له.
طيب بس ممكن تطلع شوية فوق أبص. Call to the scene by friend of the patient, 19 years old male, after he was found sleeping with an empty pill bottle next to him. Patient is currently drowsy but otherwise stable without signs of
ده
trauma.
شفناه الاسبوع اللي فات. شفناه الاسبوع اللي فات يا مهجة. The patient who took an overdose and was brought by his friend to his
هاي
college student.
عملنا
شفناه الاسبوع اللي فات.
ده عملناه.
شوف لنا واحد تاني.
دقيقة هنا. إذا ما عندي فكرة هل إذا اشتغلناه كلها هنا ده.
والله مهجة أدرى مننا يا مهجة، أنت ومحاسن أدرى من الموضوع ده. أنتوا السوبرفايزرز على الاس بي اي.
أنا بس الأسبوع اللي فات ما عارفة يشتغلوا شنو، لكن
دي اشتغلناه الأسبوع اللي فات. المهم
أخوة.
واحد بس اشتغلنا الأسبوع اللي فات. ولا اثنين ما أعرف، المهم ده اشتغلناه.
واحد التاني اللي هسه ما بيفتح ده ما فيه.
نمشي على السيم فلو.
نمشي سيم فلو خلاص، نخلص
اوكي
من
خلاص.
الكود كود يا مهجة، نمشي سيم فلو.
اوكي
خلاص تمام.
ثواني خليكم معي.
هم كاتبين 121 لكن ما اعتقد انه في 121 هنا في الكيسز دي. في
آه.
21.
في
طيب
في
في
220.
171 في 141 113 آه في
في
32
221.
في 221 لكن اشتغلناه قبل كده 221.
افتكر نمشي السيم فلو.
اوكي.
انا جوا السيم فلو بس وروني which one to choose ولا.
غايته ايميلي دي اشتغلناها قبل كده يا بس ايميلي.
ايميلي اشتغلناها أيوة. لكن أحسن يا ياسر، إحنا نمشي من البداية، ما ناخدها بهازردلي، ناخد من البداية، نشوف اللي اشتغلناه نخطها ونمشي from 1 2 3 كده، عشان
ليه ما
بعدين نكون
اشتغلنا؟
عارفين. ليلي
ما اشتغلنا
ليلي
مش.
ليلي ما
اشتغلناها
اشتغل.
خلاص. يلا ابتدي بليلي.
دقيقة دقيقة ثواني. دقيقة قبل ما نبتدي افتكر ذاته في الانفورميشن تبتدي من هنا ده الزول اللي هيشتغل الكيس.
السلام عليكم يا بوس.
عليك السلام.
أنا محمد طارق، يعني I've been with you since the beginning. بس كنت مستني كيس يكون فيها history أو MSA
تفضل.
so I can start the case.
هاي. لا يعني ليه ما في البداية في الانترودكشن بتاعي هنا مخطوط هنا ده، يعني انت should start taking من اول هنا ده.
Okay, so I should start reading. Start reading now, right?
ايوه.
Okay, طيب. Okay, scenario info. Lily is a 14 years old girl who has been referred to the local say CAMHS clinic following concerns raised by her school and teachers regarding facial tics, which have been present for 7 months. Other children have started to bully her, and it is affecting her educational achievements. Okay, the task is to take a psychiatric history and risk assessment. Okay.
افتكر ال CAMHSD stands for the Child and Adolescent Mental Health Services.
Okay. Okay. So, okay. Okay.
دي المفروض نقرا الكلام ده هنا ولا المفروض نخش طوالي احنا؟
لا أحسن يقولوا البري ريدنج يا
اوكي.
ياسر.
اوكي.
Okay. Right. A pre-reading assessment of a teenager with facial tics. This pre-reading material is designed to equip you with the necessary knowledge to conduct a psychiatric history and risk assessment for Lily. So let me zoom in a bit. A 14 years old girl referred to the Child and Mental Health Service clinic due to concerns about her facial tics. Understanding the potential underlying causes and the impact of these symptoms on her mental health and daily functioning is crucial. Okay, understanding tics. Tics are sudden, repetitive, non-rhythmic movements, motor tics, or vocalizations, vocal tics, that involve discrete muscle groups. Facial tics, like those Lily is experiencing, are a form of motor tics and can include eye blinking, grimacing, and all other facial movements. Transient versus chronic. Tics can be transient, lasting less than 1 year, or chronic, lasting more than 1 year. Type associated conditions. Tics are often associated with conditions like Tourette syndrome, persistent chronic motor or vocal tic disorder, and provisional tic disorder. They can also be linked to stress, anxiety, and other psychiatric conditions. Psychiatric history taken presenting complaints begin with open-ended questions to understand Lily's concerns about her facial tics and how they impact her life. Okay, can you tell me about the movements you've been experiencing on your face? How do these movements affect your daily activities and interactions with others? History of present illness, probe into the onset, duration, frequency, in context of the text. When did you first notice these movements? Have you noticed anything that makes them better or worse? Then psychosocial history, explore the impact on her schooling in social interactions, especially concerning bullying. How have your friends and classmates reacted to your tics? Have these reactions affected you at school or in other areas of your life? Family and medical history. Inquire about any family history of tics or associated disorders and any significant medical conditions. Does anyone else in your family have similar movements or neurological conditions? Have you had any medical problems in the past? Educational and developmental history. Assess any impact on her educational achievements and developmental milestones. Have your tics affected your schoolwork or concentration? How are you doing in school compared to before the tics started? Risk assessment, bullying and emotional impact. Understand the extent of bullying and its effects on her mental health. Can you tell me more about how other children treat you because of your tics? How do you feel about yourself and your future? Mood and anxiety. Assess for signs of depression, anxiety, or other mood disorders. Have you been feeling sad, anxious, or hopeless recently? Do you enjoy the activities you used to find pleasurable? Suicidality and self-harm is crucial to assess any thoughts of self-harm or suicide, especially given the bullying context. Have you ever thought about hurting yourself? Do you have thoughts of not wanting to be alive? Okay, your task during this simulation is to gather comprehensive information about Lily's condition, feeling empathy and understanding while maintaining a professional approach. The data you collect will be instrumental in formulating a diagnosis and developing an appropriate management plan to support Lily's mental and physical well-being. Okay? A pre-brief based on your pre-reading. What did you learn regarding the history? The question?
أيوه.
Okay, she suffers from facial tics. She's being bullied uh, due to having the due to suffering from the tics by her classmates, and it affected her educational achievements. Yeah. Are there any aspects of this topic you feel confident in? Did not understand the question actually. So if you can help me.
ده سؤال أهبل. ما عندي ما عندي رد كويس يعني ده سؤال أهبل يعني this just
Okay.
they want to assess the confidence before and after ما أكتر من كده.
My confidence in simulating or in taking history from such a case,
Yes.
I think it's low on the scale, yeah, a bit. Okay, are there any aspects of this topic you need to continue to develop? Yeah, I think I need to read more about it, study more about the text. And child psychiatry, if you can't say. Okay. Okay, scenario info. Lily is a 14 years old girl who has been referred to the local CAMS clinic following concerns raised by her school and teachers regarding facial tics, which have been present for 7 months. So cute. Other children have started to bully her, and it's affecting her educational achievements. Take a psychiatric history and risk assessment. Okay.
Hello, I'm Lily. Are you here to help me?
Hi, Lily. How are you doing? I'm Dr. Muhammad. I'm here to talk to you about what's concerning you guiding the movements that take place involuntarily on your face.
Oh, yeah, my mum said something about that. It's just my face does these weird things sometimes and I can't stop it. It gets worse when people are looking at me. I don't really like talking about it much.
Okay, firstly, I need to take some personal data from you, if it's okay.
Yeah, that's okay, I guess. What sort of stuff do you need to know?
Your full name,
It's Lily Burdett, with 2 L's in Lily.
and okay, I knew that you're 14 years old.
Yeah, I'm 14. My birthday was in February.
Okay, which class you're studying in?
I'm in year 9 at secondary school.
You're living with your family?
Yeah, I live with my mum, dad, and my little brother.
Little brother, do you have any brothers or sisters other than him?
No, just him. He's 7. Sometimes he annoys me, but he's all right.
Okay, he's younger than you, right?
Sorry, I don't get what you mean. Do you mean, is he here with me? He's not. He's at home with mum.
Okay. Do you have any friends at school or outside school?
Fines. Do you mean friends? I've got a couple, but it's been hard lately. Most people don't really talk to me much anymore.
They don't talk to you based on the movements that happen to you, right?
Yeah, pretty much. They stare or laugh sometimes. Some people say mean things. It makes me want to just hide, honestly.
Yeah, sorry to hear that actually. How long have they been taking place, these movements?
I think it started last year, maybe around spring. At first, it was just little things, like blinking or scrunching my nose. Now it's more noticeable, and sometimes noises come out too. It's gotten worse since people at school started noticing.
Do you get any warning signs before these movements take place?
Yeah, sort of. Sometimes I feel this weird tingly feeling, like something's building up and I just have to let it out. If I try to hold it in, it gets really uncomfortable.
Yeah, I can understand that. So the times they happen, how frequent were they? Did they take place on daily basis?
Yeah, it's every day. Some days it's not as bad, but other times it happens all the time, especially if I'm nervous or if people are watching me. School makes it worse.
Okay, so they happen in certain settings, right? While you are stressed out, for example.
Yeah, definitely. When I'm stressed or worried, it's way worse. Like if I have to talk in class or if someone looks at me funny, it just happens more. At home, it's a bit better, but not gone.
So they occur even at home while you're not stressed out. They happen even while you're relaxed, but they increase in frequency while you are stressed out, right?
Yeah, they still happen at home, just not as much. I feel safer at home, so I don't get as nervous. But if I'm upset or thinking about school stuff, the tics get worse, even at home.
Okay, the duration of the tics or the movements that you suffer from, how long do they usually take? Like seconds, minutes?
It depends. Some are really quick, like just a blink or a twitch. Others last a bit longer, maybe a few seconds. Sometimes they come in little bursts, one after another. Rarely it lasts for a minute or so if I get really anxious.
So as you told me that when you try to hold them or to suppress them, they increase, right? They get worse.
Yeah, if
So how did did you try to manage them? Did you try to use anything to stop them from appearing other than suppressing them? Or any you to try to relax yourself out to make yourself calm or to breathe in order to make them subside or decrease in intensity?
sometimes I try to breathe slowly or distract myself, like listening to music or drawing. It helps a little,
Oh,
but not
it
always.
helps. Okay, sometimes it helps, right?
Yeah, sometimes it helps a bit. If I'm really focused on something I like, I don't notice the tics as much. But if I'm stressed, nothing really works.
Okay, this is really good. Before they start to happen, last year, as you said, has anything significant happened to you out of normal?
Not really, I mean, not really. Nothing big happened, I think. School was just getting harder, and I felt more pressure with homework and stuff. But nothing like major.
Okay, how did they affect you, if you can explain to me?
They make me feel embarrassed, especially when people stare or laugh. I stopped wanting to go to school some days. My grades dropped, and I don't hang out with friends much anymore. I just feel really alone a lot of the time.
Okay, so was the extent so severe that you thought about dropping out of school? Have you ever thought about this?
Yeah, I've thought about it. Some days I just want to stay home and not deal with anyone. But my parents say I have to go, so I do. It's just really hard sometimes.
So after that, after you have the tics,
الكيس
and
بيفضل.
then some of, okay, so
الكيس كلها 7 دقائق فما بده زمن كتير يعني انا got tricked by this حتى يبتدي 7 دقائق بس الاسئله في
okay, I didn't know
بياخد
that
كوست.
actually. I
ايوه
went so detailed. Okay,
في الكوست بريف اللي بيسأل.
so we're trying again.
لا لا لا
Post brief. It's over. Okay. So, what do you feel went well during this simulation? Uh, well, I tried to know the aggravating factors. Or to know the impact on academic performance and social life, but I did not have the chance to continue. I did not have the chance. Okay, that went badly. Okay, didn't point it down yet. What do you feel went badly? Well, actually, yeah, time management did not have the time to elicit further on the most important thing, which was the mood and the risk assessment regarding the emotional impact on my patient. What do you think you could improve on? Yeah, well, I think time management, yeah. definitely. So should I read?
أي.
Yes. Okay. The personalized feedback, the consultation demonstrated some strengths, particularly in exploring the presenting complaints. ثانية وقوف. بعد اذنك ابص ثانية واحدة، ثانية واحدة. كيف؟ قفلها بس حاصل عشان عندك ازمة ولا شنو؟
والله ما عندي أزمة العقيد.
شكله قادر interrupted.
Yeah, I'm sorry. Just having a night shift. So أنا وقفت تمام. Just sorry. The consultation demonstrated some strength, particularly in exploring the presenting complaint and its impact on the patient, daily life and social functioning. The doctor engaged Lily in a conversational manner and elicited detailed information about how ticks, the onset and the social consequences, aligning with the user's brief recognition of the main issues, facial text, bullying and educational impact. However, there were significant omissions in several key areas. Past psychiatric history, yeah, definitely. Medical history, medication use, family psychiatric history in substance use were not addressed. Risk assessment was incomplete. Well, actually, it wasn't done, actually. Missing direct questions about self-harm, suicidality and risks from or to others, while the user acknowledged a lack of confidence and desire to learn more about tick evaluation and treatment. The consultation would have benefited from a more systematic and comprehensive approach. The lack of post brief reflection likely reflects uncertainty or lack of insight into areas for improvement. In summary, while there was a good rapport and some focused inquiry, the assessment lacked the necessary breadth and depth required for a thorough psychiatric evaluation risk assessment in a young person presenting with neurodevelopmental symptoms and psychosocial distress. Okay, information gathering, identifying key issues and priorities. The doctor identified the main concern, Lily's involuntary facial movement sticks, and the impact on her social and school life. This is evident in the quote. I'm here to talk to you about those concerns, yeah, concern you regarding I think there's something in the, okay, in the movements that take place involuntarily on your face. The user also recognize social exclusion and talk they don't talk to you based on the movements that happen to you, right? I cannot remember me saying that. However, other priorities such as mental health, comorbidities, or safety were not explored, definitely. Assessing historical context and relevance, the doctor explored when the symptoms started and how they developed, how long have they been taking place, these movements, and I think it started last year, maybe around spring. However, there was no exploration of developmental, yeah, definitely, psychiatric or medical history. The doctor could have asked, have you ever experienced anything like this before, or had any other health problems, or any family member that suffered from the same thing I had, to provide more context. نحن وين؟ I'm sorry. Okay, elicitation of presenting issues and details. The doctor elicited detailed descriptions of the text triggers, frequency, and times at management. You got any warning signs before these movements take place, and how frequent were they? take place on daily basis? And did you try to use anything to stop them from other than suppressing them? This provided a good understanding of the presenting issues. Conducting risk and safety assessment, it was not done. Risk assessment was limited. The doctor touched on school avoidance. So the cost-based sensor will be that, that what? He thought about dropping parts of school. Have you ever thought about this? But did not explore self-harm, definitely. Suicidality or risks from or to others. The doctor could have asked, have you ever felt so upset that you thought about hurting yourself? Or do you feel safe at home or at school? To ensure a thorough risk assessment, evaluating physical health in wider perspectives. There was no exploration of Lily's general physical health or medical history. The doctor could have asked, do you have any other health problems or take any medications to address this domain? Gathering psychological, social, environmental information. The doctor explored some social context. You're living with your family, okay, and have got a couple friends, but it's been hot lately. Most people don't really talk to me much anymore. However, there was no inquiry about family psychiatric history, even the family dynamics, and I needed to take history about that. Substance use or environmental stresses. The doctor could have asked, does anyone else in your family have similar symptoms or any health problems? And do you ever use substances like sugars or alcohol, especially she's a teenager? Okay, communication, consultation, structure management. The consultation was somewhat disorganized, with some repeated questions in unclear phrasing. Okay, he is what? He is in the venue. What? I did not understand this. The doctor did follow a sequence from presenting complaint through to impact, but missed several essential sections. More structured approach would help ensure all domains covered. Definitely. Consultation style. The doctor style was generally conversational and patient focused, using age appropriate language in checking for understanding if it's okay. However, some questions were unclear or awkwardly phrased, which may have confused the patient. Attitude and behavior. The doctor showed empathy and validation. I'm sorry to hear that actually. In maintained a supportive tone. There was no evidence of judgment or dismissal. Thanks God for that. Listening skills and responsiveness. The doctor responded to Lily's statements and adjusted questions based on her answers. Sometimes it helps a bit. Really focus on something I like. I don't notice statistics as much. However, some responses fail to develop the conversation or miss opportunities for further exploration. Questioning style questions were mostly open and allowed Lily to elaborate. Can you explain to me? However, some questions were leading or unclear, so the cost-based sensor will be that he thought about dropping parts of school. Have you ever thought about this? And important areas were omitted. Language use. The doctor generally used simple, supportive language, but somewhat phrase questions in a confusing way. Do you have any finds? I think I said friends. Okay. A school or high school. Well, I think what I said was in school or outside school. But forgive my language. Clearer, more direct language would have improved the interaction. I really appreciate the feedback. Okay. Anything else to read? Okay, that's it. I think I read it all. Improve the interaction.
ثانك يو. بس افتكر يعني this افتكر التريكي بارت انه الزمن للاسسمنت قصير، فعشان كده مثلا الزور الجاي يعني just to focus on المين questions.
اوكي ان شاء الله.
يعني
Thank you boss. I need you to excuse me, and I have a patient. I think he's having asthma. I just need to do some ABCs and come back to you, okay?
نمشي بالترتيب ولا نظامكم كيف احنا افتكر عملنا 7 قبل كده لكن الزمن طول فما عارف ازاي.
اي والله يا ياسر نمشي بالترتيب. انا افتكر
تمام.
نمشي بالترتيب، لكن لو لقينا two cases similar to each other we just skip the case. لو لقينا اثنين similar.
هاي.
thank you.
Thanks. طيب افتكر دي نمشي 7.
انا ما عندي اي مشكله. يس
انا
موجة، بس انت مهم سجلي الكيسز اللي شفناها يا موجة عشان تاني ما نقعد نتغلط. سجليها اي كيسز شفناها في السين فلو سجليها، يعني حسلي لي شفناها والثانيه دي نمره 2 شفناها مش كده؟ ايميلي شفناها،
إيميلي شفنا، أيوة.
وويلسون نمره 3 ده شفناه مش كده؟
ويليام، أيوة.
ويليام. وفي واحد افريكان ولا جزائري ولا عربي تتذكريه؟
أيوة برضه شفناه، أيوة.
بس سجليهم عليك الله كلهم عشان ياسر يكون عارف تاني. سجليهم عندك في ورقه وقلم عشان نكون عارفين لهم ما نرجع ليهم.
تمام
طيب
تمام.
ايوه تاني منو امشي يا ياسر؟ طيب ده منو لابس طاقيه ده شفناه؟
ما افتكر.
لا لا، ما شفناه.
طيب خلاص الكانديديت بتاعك منو تاني بعد ما طارق مشى؟ الكانديديت منو حيمسك الكيس؟
محمد
أنا
فضل.
عمر أحمد جاسم.
محمد عمر.
اه
عمر يا بوس.
تفضل تفضل. عمل ايه يا ياسر؟
اوكي. افتكر برضه في السيناريو في الاول هنا قدام اول شيء هنا ده.
طيب هارولد تشوي. سيناريو انفو. هارولد تشوي is a 79 years old gentleman diagnosed with Lewy body dementia. He's attending his first outpatient psychiatric clinic appointment on referral from his general practitioner. His wife, Julie, has reported that Harold has begun to experience hallucinations. The task take a risk assessment and mental state examination. Pre-reading introduction to Lewy body dementia, overview of dementia. Dementia is a broad term used to describe a decline in cognitive function severe enough to interfere with daily life. It encompasses various conditions, including Alzheimer's disease, vascular dementia, and Lewy body dementia. Lewy body dementia is a type of progressive dementia characterized by the presence of Lewy bodies, abnormal aggregates of protein that develop inside nerve cells in the brain. Lewy body dementia is the third most common type of dementia, following Alzheimer's disease and vascular dementia. It is estimated that Lewy body dementia affects more than 900,000 people in the UK. Risk factors include age, most common in people over 60. A family history of Lewy body dementia and certain genetics mutation. Lewy body dementia is characterized by the widespread distribution of Lewy bodies throughout the cortex, limbic system, and brainstem, leading to a decline in neurotransmitters, notably acetylcholine and dopamine, which are crucial for cognitive and motor functions, respectively. The role of Lewy bodies in neural degeneration lies in the fact that they interfere with neurotransmissions. Contributing to the symptoms of Lewy body dementia, their presence is also associated with the degeneration of nerve cells. Unlike Alzheimer's disease, which primarily affects memory first, Lewy body dementia often presents with the cognitive fluctuations, visual hallucinations, and Parkinsonism early in the disease. Diagnostic criteria and assessment tools. Lewy body dementia is characterized by a specific set of core criteria. In the ICD-11, it is categorized under the neurocognitive disorders 2, 3. Here are the core criteria for Lewy body dementia. 1, fluctuating cognition. There are pronounced variations in attention and alertness. A person with Lewy body dementia may have significant fluctuations in their cognitive function, where they exhibit periods of clear thinking and periods of confusion or inattention. Visual hallucinations. These are typically well-formed and detailed. Patients often experience recurrent visual hallucinations that are usually vivid and detailed. Parkinsonism. Movement issues are present, similar to the observed in Parkinson's disease, which might include slowness of movement, stiffness, and tremor. Rapid eye movement, REM sleep behavior disorder. This involves acting out dreams, which can include talking, yelling, or moving limbs during REM sleep. This can occur before other symptoms have become. Severe neuroleptic sensitivity. Patients may have a pronounced adverse reaction to neuroleptics, antipsychotic medications, which can exacerbate symptoms or lead to severe side effects. For a diagnosis of Lewy body dementia, at least 2 of these core features are typically present, with one of them being either fluctuating cognition or visual hallucinations. Or one core feature is present alongside one or more indicative biomarkers. It is crucial to conduct a thorough assessment, as these symptoms can overlap with other conditions like Parkinson's disease and Alzheimer's disease. Considerations for taking history. When taking a history, performing a risk assessment, and conducting a mental state examination in an elderly gentleman with symptoms suggestive of Lewy body dementia, it is important to approach the session with empathy and understanding, given the complex nature of Lewy body dementia symptoms. Here are some questions and consideration to guide your assessment. Cognitive and memory function. Do you have noticed any changes in your memory or thinking skills recently? Do you have moments when you feel more confused or less alert than usual? Can you describe these moments? Fluctuating cognition. Do family members or friends notice that there are times when you seem more yourself and other times less so? Have you experienced any sudden changes in your attention or alertness? Have you seen anything that others can't see? Can you tell me about these experiences? For visual hallucinations, have you seen anything that others can't see? Can you tell me about these experiences? Do these visions seem real to you, and how do you feel about them? Movement and Parkinsonism. Have you felt more anxious, depressed, or irritable lately? Have there been any changes in your personality or the way you behave? Functional abilities and daily living. How are you managing your daily activities like dressing, eating, and shopping? Have you needed more help from others for your daily routines? Risk assessment. Do you ever felt like harming yourself or felt that life is not worth living? Do you feel safe at home? Have there been any falls or accidents recently? Support system. Who do you rely on for support? How are your relationships with family and friends? Is there someone who helps you with your medical care and daily needs? While asking these questions, observe the patient's appearance, behavior, mood, and cognition and cognitive functions. Take note of any fluctuations in alertness, attention, and coherence in the response, as they can provide valuable insights into their mental state and the severity of Lewy body dementia symptoms. Always use a gentle, reassuring approach. Recognize that discussing these topics can be challenging for the patient. Based on your pre-reading, what did you learn? I learned about Lewy body dementia symptoms and the impact of it on a patient. Is there any aspects of this topic you feel confident in? Maybe asking about the symptoms. Is there any aspects of this topic you need to continue to develop? Language and showing empathy, maybe. Communication.
جاهز؟
إن شاء الله.
Okay.
Oh, hello there. What's this all about then?
Hello, Harold. How are you?
I'm
I
not
am the.
sure, really. Things feel a bit muddled today. Have you seen Julie? She usually helps me with these things.
I haven't seen Julie. I am Dr. Omar. I am here to help you today.
Oh,
So what brought
Julia.
you? So what brought you here today, Harold?
I'm not sure. Julia said I had an appointment. She's not well today. Coughing, maybe. Everything's a bit fuzzy.
Can you tell me more about it?
It's hard to remember, really. She just told me to come here. Something about me seeing people. But I don't think it's strange. They were just in the house, weren't they?
Can you describe these people that you see in the house?
There, just there, sometimes by the window, sometimes in the hallway. A man with a hat and a little girl. I tried talking to them, but they don't answer. Julia never sees them.
Do other people see these two peoples with you, Harold? Do they notice them?
No, no, just me, I think. Julia
Okay.
always says there's no one, but they seem real. Sometimes they move things. It gets a bit confusing.
Okay, I'm sorry to hear that. Seems hard. Do you feel confused a lot?
Yes, very much. Things slip away. I forget where I am or what I'm doing. The days all blur together. Julia helps me find my way.
Okay. Did Julie ever told you that you are starting to become forgetful? I'm sorry to say that.
Yes, she says I forget things. She writes notes for me. I don't always remember what's been said. It's upsetting sometimes. I don't like making her worry.
Okay, I'm sorry to hear that. Do you sometimes feel like your hands are shaking or that you have any abnormal move with your body?
Robotic? No, I don't think so. Sometimes my hands are shaky. Yes, but not like a robot. Just
No,
old, I suppose. Sometimes they feel stiff.
okay, I'm sorry. I didn't say robotic. I said abnormal, but I'm sorry to say that. How about your attention? Do you find your attention declining in the past weeks?
I think so. Hard to focus. Things slip away quick. I start something, then forget what it was. Julia reminds me what I'm meant to do.
Okay, I'm sorry to hear that. So where did you study high school, Harad?
Long time ago, in England, I can't remember the name now. It's all a bit jumbled these days.
Okay, I'm sorry to hear that.
That's kind of you. Thank you. It's all a bit much sometimes, you know.
What about your mood recently? How do you feel?
It changes. Sometimes I'm alright, sometimes sad or frustrated, especially when I can't remember. I miss how things used to be.
I'm sorry to hear that. It seems hard to say that.
Yes,
So this is
it is. Thank you for being gentle. It's hard to talk about sometimes, but thank you.
you are welcome, Harad. I'm here to help you. So this is
That's kind. I hope Julia feels better soon. She usually knows what to say.
okay. So this is your first appointment with a doctor in this issue.
Is it? I can't remember. Maybe it is. Everything's a bit mixed up. I just do what Julia says.
Okay, I'm sorry. Do you sometimes think or feel that you should harm yourself or someone else? Both brief.
Yeah.
What what do you feel went well during this simulation? I think empathy, showing empathy. What do you feel? What do you feel went badly during this simulation? Didn't complete the history taking. What do you think you could improve on? I think history taking. Right. Now, assessment, overall performance, borderline fail, personalized feedback. The doctor demonstrated some empathy and attempted to engage with Harold, a patient with Lewy body dementia, presenting with hallucinations and cognitive decline. There was an effort to explore the patient's experiences and mood, and the doctor responded with supportive statements when distress was expressed. However, the assessment was incomplete in several critical areas, notably risk assessment and systemic mental state examination. The questioning was often fragmented, and key domains such as risk to others, risk from others, and insight were not adequately explored. The doctor did not thoroughly assess for safety, physical health, or the broader social context, nor did they structure the consultation effectively. While there were moments of compassion, the overall interaction lacked the depth and organization required for a comprehensive psychiatric assessment. The post brief reflection on empathy was accurate, but there was little evidence of skills in risk identification or structured communication. Fail. Information gathering, identifying key issues and priorities. The doctor attempted to identify some key issues by asking, "So, what brought you here?" "Hello, I'm following up on hallucinations and memory problems." However, the approach was somewhat unfocused, and there was no explicit prioritization of urgent concerns such as risk of safety. A more effective approach would have included direct exploration of risk. For example, have you had any thoughts about harming yourself or others? أعتقد قلتها لكن ما سمع ما مشكلة. Assessing historical context and relevance, the doctor made a minimal attempt to gather historical context, asking, "So this is your first appointment with the doctor in this issue," but did not pursue details of past psychiatric, medical, or family history. There was no exploration of the timeline or progression of symptoms. A helpful question could have been, "How long have you been experiencing these difficulties?" Elicitation of presenting issues and details. The doctor elicited some details about hallucinations. Strive these people that you see in the house, describe these people that you, this is what I said. And cognitive symptoms. Did Judy ever told you that you are starting to become forgetful? I am sorry to say that. But the questions were often unclear and lacked follow-up. There was no systemic exploration of symptoms, onset, duration, or impact on daily life. Conducting risk and safety assessment. Risk assessment was notably weak. The doctor made an incomplete attempt. Think or should harm yourself, but did not follow through or cover risk to others. Risk from others or neglect. There was no assessment of suicidality, safety at home, or vulnerability. A more thorough approach would include, do you ever feel unsafe at home or worry that someone might harm you? Uh, Evaluating physical health and wider perspectives. There was a brief mention of physical symptoms, your hands are shaking, or that you have any abnormal move with your robotic. فهمني غلط بس but this was not clearly explored or contextualized. No questions were asked about general health, medications, or comorbidities. The doctor could have asked, do you have any other health problems or take any regular medications? Gathering psychological, social, and environmental information. The doctor touched on the support provided by Julia. Julia helps me find my way, but did not explore the patient's social environment, supports, or psychological stressors. There was no inquiry about family, living situation, or social activities. A helpful question could have been, who do you live with, and how do they help you day to day? Okay. Communication, consultation structure and management. The consultation lacked clear structure and abrupt topic changes and incomplete questions, such as movies sometimes, and think or should harm yourself or others. The doctor did not summarize or signpost, leading to a disjointed interaction. Okay. Consultation style. The doctor attempted to be supportive and gentle. I am sorry to hear that. It seems hard to say that, but the style was inconsistent, sometimes losing focus or clarity. The approach was not always well adopted to a patient with cognitive impairment. Attitude and behavior. The doctor attitude was generally kind and apologetic. You are welcome, and I'm here to help you, which fostered some rapport. However, the uncertainty and fragmented nature of the conversation may have undermined patient confidence. Listening skills and responsiveness. There was evidence of listening. I am sorry to hear that. It seems hard to say that, but the doctor often failed to build on patient responses or clarify ambiguous statements, missing opportunities for deeper understanding. Questioning style. The questioning was often unclear, fragmented, and sometimes confusing for the patient. Your hands are shaking, or that you have any abnormal move with your robotic. ممكن تكون language itself. The doctor did not use open-ended or follow-up questions effectively. Language use. Language was sometimes convoluted and difficult for the patient to follow. I didn't say it, or I don't know. Robotic, I said that abnormal word. I'm sorry to say that. clearer, simpler language tailored to the patient cognitive level would have improved communication. Okay.
شكرا جزيلا يا عمر. أنا I think you did well, very well الحقيقة. I agree with you. هم الأكسنت sometimes طبعا بيسجلوها بطريقتهم، بيسمعوها بأذن مختلفة، لكن this is good. الملاحظات اللي قالها هو ممكن يقولها لأي زول تاني لو أي زول فينا عمل الانترفيو دي حيقولها له، لكن we need أهم نقطتين قالوا we need to be systematic في الهيستوري تيكينج. بس نرجع طوالي نحن للهيستوري، لما ناخذ هيستوري بسأل عن شنو 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 شنو، يعني امشي في الهيستوري كانك بتتعامل مع اي بيشنت انت شفته. والمنتل ستيت اكزامينيشن فهو قال فراجمنتد وقال ما سيستماتايز، لانه احيانا نحن في الانترفيو بنضط من حته لحته من حته لحته، فما بتكون كستوري ماشيه بالتدريج سلسه. فايتس فيري
صح.
امبورتنت، لكن generally it is good, it's very good الحقيقه. والحكايه دي when you are interviewing a patient with English speaking patient ما زي العربيك speaking patient او السودانيز accent، اسهل كتير دي. لكن نحن
صح.
هنا we will improve our skills definitely. وزي ما قلنا نحن الاسبوعين بتاعت السين فلو دي we are interviewing patients English speaking patients، لكن الاسبوعين بتاع الكيس برزنتيشن بتكون بالعربي، لانه بيقدموا حالات شفتوها في المستشفيات شفتوها في المراكز وتكون بالعربي. ف well done. وبرضه دكتور محمد طارق he did well يعني. thank you both of you.
شكرا دكتور عبد الله.
في مجال لكيس تاني الليلة ولا؟
مهجة. برضه لو في اي كومنتس من الترينيز يس اي كومنتس على التو كيسز دي please feel free to comment or to ask.
السلام عليكم ورحمة الله وبركاته. شكرا لزملائنا اللي قدموا، تحية للغرفات وأساتذتنا الكرام. أنا بس عندي سؤالين من الهيستوري طبعا، لأنه أنا طبعا أنا في السنة الأولى لسه. when I am clerking بعض المرات بحس روحي confused. مثلا إذا جاتني مثلا symptom بتاعت persecutory delusion، فهل أنا باخدها في الهيستوري وين؟ ولا باخدها في المنتال ستيت بس؟ وإذا حطيتها في المنتال في الهيستوري بعبر عنها بطريقة مختلفة ولا كيف التعبير بيكون؟ دي الحاجة الثانية الريسك اسسمنت.
نخلص من الحاجة الأولى أحسن، دقيقة نخلص من الحاجة الأولى يا خلف الله.
طيب خير.
طيب. قول البيشنت لما بتعمل في كلاركينج قال لك شنو؟ قول لنا مثال قال لك شنو أنت حسيت إنها persecutory delusion، قال لك شنو البيشنت؟
ايوه زي مثلا يقول لي في جهاز بتاع تصنت مركب في بطني، او في واحد قال كده.
أوكي.
وواحد
طيب.
بيقول في ناس لاحقينه دايرين يقتلوه او كده ودايرين يزوه.
طيب فيري جود. دي بتكتبها وين في الهيستوري؟
طيب انا كنت في البريزنتنج كومبلين بكتب بيقول عليه شنو abnormal speech او odd speech.
ابدا ابدا. انت الكومبلينت دي لو هو جاك بس قال لك والله انا جيت المستشفى لانه في حاجتين، في ناس مطارديني وعايزين يقتلوني، وبرضه في ناس خدت لي جهاز في بطني ولا في البيت بيتابعوني، بس دي الكومبلينت بتاعته. اوكي، دي المين كومبلينت.
طيب.
فهنا الكومبلينت دي انت الكومبلينت دايما مختصره والديوريشن بتاعتها the patient believes that there is an instrument ولا a device being hidden so that they can spy on him for the last 1 week 1 month 1 year تكتبها. الحاجة الثانية the patient believes that some people are chasing him and are trying to harm him ديل لما تكتب التو كومبلينز ديل ما في اي مشكله لو كتبت الفيرباتيم اوف ذا بيشنت تحت كل واحده فيها. والله يا دكتور في ناس خدت لي جهاز في البيت وفي مرات في بطني جوا بيجي عايزين يتجسسوا علي، تكتبها بين قوسين ممكن.
اوكي اوكي
كتبت
تمام.
الكومبلينت بالانجليزي تحت طوال الفيرباتيم تكتبها ذا فيرباتيم اوف ذا بيشنت. الكومبلينت الثانيه تكتبها بالانجليزي وتحت طوالي بين قوسين الحاجه اللي قالها ليك بالعربي عديل بلهجته كمان والديوريشن. نجي بعد ذاك هتكتبه وين تاني؟ بان ديتيلز في الهيستوري بريزنتنج illness، وتاني
اوكي
هتسالها في المنتال ستيت اكزامينيشن. يعني دي في 3 مواقع، في المين كومبلينت اوكي
اوكي
هتجيبيها،
تمام.
والديتيلز حقت الكلام ده لانه ده حسي سطر واحد ما فيه ديتيلز. والحاجه الثانيه هتكتبها
ايوه
في بعد المين كومبلينتس تكتبها في الهيستوري بريزنتنج illness ان ديتيلز. وفي الحاله زي دي انت هتسال عن سكرينينج كويشن عن حاجات كثيره. ده هو اداك الدايجنوزيس في طبق من ذهب جاهز. لكن to confirm it you need to ask about other diagnostic criteria. وما تقول delusions ولا hallucinations ولا thought position ولا thought withdrawal. هنا بتشرح بس بالانجلش لانجويج. اتس نوت ا جانك اصلا ما بتذكر حكايه في الهيستوري بريزنتنج illness. لما تيجي منتال ستيت اكزامينيشن
اوكي
وقدمت البيشنت ده وجيت للثوت بروسيس تقول this patient has مثلا persecutory delusions. لو لسه معاه
اوكي
لحد ما يوم ما انت ما شفته لانه هناك داك هيستوري. ممكن الهيستوري يقول لك الحكايه دي لها سنه او سنتين او 6 شهور او شهر. today المنتال ستيت اكزامينيشن از هير اند ناو. اوكي يا محمد احمد الليله لسه انت الجهاز اللي خدتينه لك في بطنك ده لسه فيه؟ لا يا دكتور انتهى لانه ادوني علاج وانتهى مثلا. فهنا في المنتال ستيت اكزامينيشن يو هاف تو بروف انه الديلوجن لسه موجوده ولا لا and you have to challenge الديلوجن دي. ولو hallucinations
تمام.
ولا mood
اوكي
ولا whatever it is. كده جاوبتك؟
لا لا كده تمام واضح أوي تمام. يعني في
طيب
البريزنت كومبلين ما بكتب مثلا يعني كلمة مختصرة زي abnormal belief أو abnormal أو odd
لا
belief
لا لا ما احنا قلنا في
أو
الكومبليت
أو
كتبناها ما
أو odd
abnormal belief. The
perception
patient
مثلا.
believes كده
إذا
patient
كان فيها
believe
hallucination ممكن نكتب odd perception مثلا.
hallucination يعتى فيهم. عندنا 5 hallucinations يعتى فيهم يعتى hallucination.
يلا يعني مثلا في تكون auditory مثلا إذا كان بيقول auditory
auditory
hallucination.
الكومبلينت the patient hears voices talking to him for the last 1 month. لما تجي في history presenting illness لا تكتب perception لا تكتب hallucination. The patient came said today to my clinic he said that he has been hearing voices for the last 5 months. These voices he said that women and men they are talking to him directly or they are talking about him among themselves. They are commanding him, commanding voices. They are ordering him, abusive voices, praising voices, and he responds to the voice of كده. تكتب الديتيلز كلها بعد ذاك في الهيستوري presenting illness.
أوكي تمام
All right.
تمام. خير يا بس شكرا. يلا السؤال الثاني برضه هو قريب الكلام ده اللي هو الريسك اسسمنت. انا كان لي انه بعمل لي انكلوجن في الهيستوري بريزنتنج كومبلين. هل ده مكانه ولا عنده برضه مكان ثاني؟
الريسك اسسمنت مهمه. ما انت
انه
بتسال اسئله. الريسك اسسمنت دي انت
التريسك.
بتسال البيشنت اسئله كلها كده بتسال. بعدين ممكن تعمل تايتل للريسك اسسمنت انت بعد ما سالته. حسي دي قال لي انا بكل وضوح في الكيس الاخير اللي شافها عمر قاسم. الريسك
ايوه
عليه هو، الريسك على الاذرز، الريسك اوف هارمينج هيم سيلف، الريسك اوف
ايوه
فولينج داون لانه ده كيس بتاعت ديمنشيا وكيس
ايوه
عنده تريمرز والمشي بتاعه فيه مشكله. الريسك اسسمنت على كل من الانفايرمنت من الاذرز على نفسه على الاخرين. دي كلها بتساله.
تمام. ممكن نعمل لها نضيفها بحيث البريزنتنج كومبلين.
الاسئله بتضيفها بتسالها انت ضمن يعني حسي زي البيشنت ده لو كان قال لي اوكي uh, uh, how do you um, finish your daily activities? How do you go? Do you need help when you go to your bed? Do you need help when you go to the toilet? Who is preparing your bed for you? Walking out to the garden. Have you ever fell down? دي الريسك بتاع الانجري والفولينج لانه دي ريليفنت للكيس دي ما لاي بيشنت ريليفنت للكيس دي. لكن have you ever thought of harming yourself? Have you ever felt unsafe? You are not safe at home? Have you felt that someone may harm you? ما دي بتسألها كده عشان بعدين في الديسك
اوكي.
اسسمنت انت بتقولها.
مم.
يس يا مهجة، عندنا حالة ثانية ولا
اوكي
ما
تمام.
عندنا؟
تمام. شكرا
والله
جزيلا.
مهجة،
إذا كمان ما في مشكلة. آه
ما الناس اللي عندك منو ثاني؟ الناس اللي عندك في الليستة
في
الليلة.
فاطمة لكن ما عارفة موجودة ولا لا.
فاطمة انت
هم
موجودة
الشباب
ولا
ديل
ما
ذاته من
موجودة؟
الأسبوع اللي فات كان المفروض يكونوا 3.
فاطمة
أنا ما
حسن
عارفة.
موجودة. فاطمة حسن موجودة.
أوكي.
يلا يا فاطمة unmute yourself. ميكروفونك ميوت. فاطمة حسن. يا اخواننا الناس بتخش السيشن ده يا ياسر ويكونوا خاشين فيه اونلاين ويمشوا حتة بعيدة ولا شنو؟
فاطمة معانا؟
موجودة فاطمة.
أنا عارف فاطمة.
يا فاطمة حسن، انت شايفينك ان موجودة في السيشن ده لكن انت ما موجودة الحقيقة. لو موجودة unmute yourself قولي انا موجودة لانه الدور عليكي. ما هو
المشكلة
كمان ما ممكن الزول يدخل نفسه ويمشي ويخلي المحاضرة وهو داخل اونلاين عشان يقول حضرتها. القصة ما اتندنس بس، القصة حضور فعلي يا اخواننا. يعني دي حاجة ما تستغفر الله العظيم نقول شنو. بنعمل في الشغل ده لمصلحة الجميع. للمرة الأخيرة فاطمة حسن، أنا أعتبرها غياب بس، نعتبرها غياب. أوكي في تاني منو غيره؟ Who is going to take أي زول؟ إحنا تاني قلنا يا مهجة، أنا كلمت محاسن المرة اللي فاتت. ما تكلموهم مسبقا في نفس السيشن. عندكم لستة تقولوا فلان وفلان الليلة يلا طوالي. لحد حسي أنا المسجلهم، لحد حسي المسجلهم 21 واحد مما بدينا الدورة التدريبية الكلينيكال دي. 21 واحد قدموا بتاعنا الليلة، ونحن عندنا 104، يعني عندنا 80 واحد ما قدموا. فبليز انت ومحاسن لما يكون عندكم سيشن تاني ما في يجهزوه ولا طوالي زي الليله دي بتكون
أوكي
مفيده
تمام.
اكثر. اوكي مفيده اكثر. انتوا
تمام.
براكم تشوفوا الليسته بتاعت الترينيز وتقولوا لما يبتدي السيشن يلا يا فلان قدم، يلا يا فلان قدم بعده. حسي في زول عايز يقدم يا اخواننا؟ فاطمه حسن دي ما ردت علينا. في اي تريني عايز يشوف كيس؟ عندنا نص ساعه. نختار. اختاري يا موجة، اختاري اي زول بس. امشي
طيب.
للبارتيسيبنتس هتلقي الناس زاغت، كانوا 90 بقوا 77 حسي.
إيه ريم صلاح الدين.
يلا يا ريم صلاح الدين، ما قدمت قبل كده؟ اشوف لك الليسته بتاعتي، انا قدامي الليسته. اشوف ريم صلاح الدين. فاطمه حسن ذاتها قدمت يا مهجه قبل كده يوم 6
آه
7. فاطمه حسن قدمت. فاطمه حسن قدمت. ايمان عمر الطيب قدمت. ايات حامد حجازي قدمت. فتحيه سعيد قدمت. محمد ابراهيم ادم قدم. فاطمه الزهراء قدمت. خلف الله قدم، هنيدة قدمت، إيمان كمال قدمت، إيمان تاج الدين قدمت، مصعب حسين قدم، هديل المهدي قدمت، يوسف فضل الله قدم، نمارق الحسن قدمت، مصطفى عبد المجيد قدم، قبل الأنبياء إدريس قدم، أسماء علي الطيب قدمت، أحمد سيف الدين سرهوري قدم، ملاذ محي الدين قدمت، محمد طارق وعمر أحمد قاسم الليلة. يلا يا ريم صلاح الدين، مهجة اختارتك.
شكله عندنا ناس قاعدين مسجلين حضور
موجودة،
وما
ما هي
فيش.
مسجلة، ريم دي مسجلة.
ري موجودة أيوة. في رزان
أها،
برضه بكر، في رزان بابكر
لا
لا
موجودة.
احنا
كده، لا
الظاهر
عايزين نشوف، عايزين نشوف الظاهرة بتاعت إنه زول يخش ويكون ما موجود في المحاضرة. دي ظاهرة غريبة.
في مشكلة دي.
والله مشكلة يا ياسر، مشكلة كبيرة. إنه الزول يخش بس حسن يكون أونلاين هو وهو ما في. أنا ما شايف ريم صلاح الدين دي وين؟ أيوة ريم صلاح الدين، يا ريم صلاح الدين موجودة؟ معناها هنعمل لهم كده، معناها هنعمل لهم كده، زول
أيوة
يخش
يا بس
أونلاين.
موجودة بس عشان في جوطة.
ما في جوطة. يلا موجة طلباتك يلا.
حاضر.
فينسنت.
أيوة فينسنت.
اوكي. ريم ممكن تتفضلي تقري هنا السيناريو بتاع فينسنت. مشيت وين؟ ريم. ريم موجودة؟
ألو.
ايوه.
ألو.
سامعينك يا ريم.
ألو سامعني؟
سامعينك.
طيب Vincent is a 27-year-old gentleman with a known diagnosis of paranoid schizophrenia for which he is prescribed a depot. His community psychiatry nurse has requested an urgent review. A task, take a risk assessment and mental status examination. هكمل؟ سامعني؟
سامعينك.
واصل واصل طوالي سامعينك عشان نكسب الزمن. اصلا ما تسالي تاني سامعني ولا لا، سامعينك طوالي تواصلي وما تقيفي.
حاضر. Assessment of a patient with paranoid schizophrenia. This material is designed to prepare you for an OSCE simulation involving Vincent Agoma, a 27-year-old patient with a diagnosis of paranoid schizophrenia. The focus will be conducting a risk assessment and a mental state examination, emphasizing the nuance of communication and engagement with patient experiencing severe mental illness. Understanding paranoid schizophrenia. Paranoid schizophrenia is a subtype of schizophrenia characterized by a prominent delusion of persecution or conspiracy and auditory hallucinations. Patient may exhibit anxiety, anger, aloofness, and argumentativeness, often due to their delusional beliefs. Symptoms: delusions, hallucination, disorganized speech, disorganized or catatonic behavior, and negative symptoms. Example: diminished emotional expression. Treatment often involve antipsychotic medications, psychosocial intervention, and support for community living. Building rapport. Approach Vincent with respect and empathy. Use open body language and maintain appropriate eye contact. Active listening. Pay close attention to his words and nonverbal cues. Validate his feeling without endorsing a delusional content. Clarity and simplicity. Use clear, conscious, and jargon-free language to facilitate understanding. Addressing delusions. Acknowledge his experience without confrontation or agreement. Focus on how his belief affect his feeling and behaviors. Psychiatric history and risk assessment. Current presentation. Understand why the community psychiatric nurse requested an urgent review. What has been happening recently that prompt your nurse to schedule this appointment? How have you been feeling in the last few days or weeks? Symptom review. Inquire about specific symptoms of schizophrenia, focusing on any change or escalations. Have you been hearing or seeing things that others cannot? Do you have any beliefs that others find unusual or difficult to understand? Medication adherence. Assess his adherence to the prescribed depot medication. Have you received your recent depot medication as scheduled? Have you noticed any change since your last injection? Risk assessment. Evaluate risks to himself, to others, and from others. Considering his current mental status, have you had any thoughts of harming yourself or others? Do you feel that someone is trying to harm you or pose a threat to your safety? Mental state examination. Appearance and behavior. Note his grooming, attire, eye contact, motor activity, and any unusual movement or gestures. His speech. Observe the rate, volume, fluency, and coherence of his speech. Mood and affect. Assess his expressed and observed emotional state, looking for congruence or disparity. Thought process and content. Evaluate the logic, flow, and coherence of thoughts. Presence of delusions or thought disorder. Perceptual disturbance. Check for hallucination or unusual sensory experience. Cognition. Briefly assess his orientation, attention, memory, and general knowledge. Insight and judgment. Gauge his awareness of his illness and ability to make reasoned decisions. Your objective in this station is to gather a comprehensive understanding of Vincent's current state through empathic and effective communication. This will inform your assessment of his risk and needs, guiding further management to ensure his safety and well-being. Based on your pre-reading, what did you learn?
دي في الكيسز القبالة الناس اللي حضرت كانوا بيختاروا بيدوسوا بيقرروا مثلا في حاجة معينة بيقولوها قبال based on the information. الاثنين اللي قدموا قبعة عليك كانوا بيكتبوا في كلام الحاجات اللي اتعلموها من السيناريو نفسه، المعلومات عن الكيس ذاته.
ما سامعة.
حضرتي كيس قبل كده يا ريم؟ حضرتي الكيسز اللي فاتت؟
أيوة حضرتها.
طيب كانوا بيعملوا شنو هنا في البري بريف؟ زملائي كانوا
مثلا
بيعملوا شنو؟
كنا بنتكلم مثلا على إنه how to address a patient و how to show empathy, how to take a history.
في البري بريف هنا في البري بريف كانوا بيجاوبوا على الأسئلة دي. لو حضرتي كان بيجاوب على الأسئلة دي في البري بريف. هنا السؤال شنو؟ أقري السؤال.
Based on your pre-reading, what did you learn?
أها، قولي.
How to make a
ياسر
risk assessment.
ياسر بيكتبها، أنت بس قولي. I learned. What did you learn? I learned. I have learned.
To make a
شنو؟
risk assessment.
أها. بس دي الحاجة اللي
uh,
you learn.
importance of emphasizing with the patient.
emphasizing شنو؟
Emphasizing with the patient complaint.
كيف emphasizing with the complaint؟
يعني how to show empathy.
empathizing معلش. اوكي. تاني هنا.
Are there any aspects of this topic you feel confident in? Uh, this topic I need to continue. Taking history.
This is very open, very vague.
Yes.
بنتكلم على التوبيك، ما مثلا taking history دي ما التوبيك، على التوبيك ده من الانفورميشن اللي خد قبل شويه.
How to support the patient, multidisciplinary system involving a family, psychosocial.
This is very big برضه، حاجه specific.
Are you confident? Are you confident in assessing the risk? مثلا, are you confident in risk assessment of this patient?
Yes.
طيب ما نقول I am confident in assessment of this patient.
Performing a risk assessment.
ثاني confident شنو؟ mental state examination. Are you confident?
Yes. Performing a
conducting
mental assessment.
systematic mental state examination.
Yes.
Alright. السؤال اللي بعده.
Are there any aspect of this topic you need to continue to develop? For me, مثلا how to help the patient after the period of medication. Yeah.
How to help the patient شنو؟
How to perform مثلا psychotherapy after taking medication. How to perform a family therapy مثلا. How to help a patient after that.
Okay.
يعني you need the psychological intervention rather than the biological intervention مش كده؟
Yes.
You need to improve your skills in psychotherapy or
Psychological
psychological.
intervention. Yes.
Psychosocial intervention. Okay.
Psychological.
Psychosocial intervention.
Yes.
alright هنخش في الكيس بعدها.
كفاية أيوه.
So-called professional that's going to lock me up. What do you want?
كلم يا ريم.
Hi, I'm
Reem.
Dr. Rim Salah. I'm your psychiatric for today. How can I help you?
You can start by getting these people out my head, yeah? I know what you're up to. Don't act like I'm stupid. You working with them too?
معلش بس سمعت ممكن تاني؟
قال لك you
You're
can
still there.
ها؟
قال لك أنت معاهم. أنت ذاتك معاهم مع الناس اللي talking my head. أنت ذاتك معاهم. قال لي أنا غبي. قال لك بالعربي الفصيح عشان ما نسمعه بالإنجليزي. هترد عليه شو
I'm
تقول
sorry,
له؟
I'm here just to help you.
What are you even
ممكن
saying? You trying to mess with my head more? Speak sense. You sound just like the voices, mumbling rubbish. Stop it.
بيشاكل فيك ها؟ أنت لما خلاص في بيشنس بيشاكلوا كده نعمل لهم شنو يا إخواننا؟ We need to
Reassurance.
Are you still
absolutely
there?
reassure them. No, I'm sorry. هتقول لي شنو؟
ما توقفي لانه لو في بالزمن
No, I'm not here. I'm just a psychiatric doctor. I'm here to help you only.
You don't need to stop. You people don't care. You just want to watch me fall apart. What's next? You gonna try lock me away again?
No, I'm not gonna lock you again. I'm here to hear what you have to say.
You say that now, but you're writing everything down, aren't you? Watching me like I'm some animal. The voices say you're trying to poison me. You want to know what I have to say? I can't even think straight with them screaming at me all day. Why should I trust you?
You should trust me because I'm here to help you.
Help how? You got something that's going to shut these voices up because nothing works. All you doctors just talk and talk, never listen. Why should I believe you any different?
I'm listening right now, and I will give you something to stop the voices.
Yeah, you really got something? Because nothing you lot give me ever works. The voices just get louder. They tell me you're lying. They say you want me dead. Why would I trust you?
Of course, I will give you something. Just I have to hear what you have to say first. I need to know all what you have been going through.
ابتدي اساليه طيب.
No? I said
How
the
many
voices don't
voices do you
stop.
hear?
They keep telling me things, horrible things. They want me to hurt myself. They want me to hurt others. I can't get away from them, not even when I use. You happy now?
Did you try to hurt yourself before?
Yeah, I don't think so. I've been eating glass these last few days. You happy now? That's what you wanted to hear. Maybe next time I'll do what the voices say and hurt my neighbor too. They're the one controlling it all.
Did you try to hurt anybody else?
Not yet, but the voices keep telling me I have to. They say my neighbor's the one behind all of this. If they don't stop, I might have to do something. It's getting worse every day.
How many voices do you hear?
There's more than one, sometimes two, sometimes five. They all sound different, but they talk over each other, shouting, screaming, laughing. Never quiet, not even when I try to sleep.
Do you hear them inside or outside of your head?
You're outside, but sometimes it's hard to tell. The voices they get in mess with my thoughts. Sometimes I don't even know what's real. Are you sure you're not one of them?
Do the voices plant ideas in your head or they broadcast some of your ideas outside?
It's them, always them. They shove thoughts in my head, make me think things I don't want. And sometimes I swear they make my thoughts loud like other people can hear. My neighbor, he hears them too. He's part of it.
Do you see them, the people talking? Do you see the people who talks? I don't know how to say. Do you see the voices that is talking to you?
No, I don't see them, but I feel them, like they're right behind me or in the walls. Shadows moving. I know they're there, watching me, laughing at me. I can feel them even if I can't see them.
You see the shadows?
Sometimes, yeah, out the corner of my eye. They move when I turn my head. I know they're real. Nobody believes me. They're always watching, waiting for me to slip up.
Do you feel like there's anyone who wants to hurt you except your neighbor?
Yeah, loads of them. Everyone in this place, even you right now, you all look at me like I'm crazy, planning things behind my back. I can see it. The system, the doctors, the people in the building, all of you want to see me gone.
Do you feel like are you going to act upon these voices?
I don't know, maybe. They're getting louder, pushing me harder. It's like I can't fight them off much longer. If something doesn't change, I might do what they say. I can't take this much more.
What are the voices order you to do?
They tell me to hurt myself, eat things I shouldn't, like the glass. Sometimes they say I have to hurt my neighbor or else things will get worse. They say I got to end it or make someone pay. It's never quiet.
Okay.
So what? You're just going to sit there and write that down? You're going to actually do something or just let me rot here with these voices tearing me apart?
For how long these voices are with you?
Long time, years. Since before I lost my place, before I got this flat. They never leave me alone. Worse now since I stopped the meds. Every day's hell.
Did you went to a psychiatric doctor before?
انتهى هي 7 دقائق كلها. البوست بريف questions.
What do you feel went well during this simulation? How the patient describe his voices, the voices he hears. What do you feel went badly during this simulation? Time management. What do you think you could improve on? How to take history faster?
يلا ده الاسسمنت. الناس الكبار قروها.
أقراها؟
الناس الكبار قروها.
هذيك الله يسوع، معلش يا ريم، حضرت الكيسز قبل شويه؟
أيوة
جد يعني؟
حضرتها والله يا بس
طيب ما شفتيهم لما تجي الاسسمنت دي بيقروها؟ ما شفتيهم؟
ما أنا قلت عشان هسه الزمن، لكن ما
ما
مشكلة
في حاجه
بقراها.
اسمها زمن. assessment أقرب.
Overall performance borderline fail. Personalized feedback. The doctor demonstrated some effort to engage the Vincent Aguma and perform elements of risk assessment and mental state examination, but there were significant gaps in both structure and depth. The transcript shows attempts to ask about hallucination risk to self and others and some clarification about the patient experience. However, the assessment was superficial, lacking through exploration of risk factors, cognitive states, physical health, and social context. The consultation features frequent communication breakdowns, poorly structured questions, and insufficient responses to the patient distress. The doctor's brief indicated confidence in risk assessment and mental state examination, but this was not fully realized in practice. More training is needed in structure assessment, formulating clear questions, and demonstrating empathy and containment with distressed psychotic patients. Information gathering. Identifying key issues and priorities. The doctor attempted to address the patient's main complaint, distressing voices, asking, "How can I help you?" and later stating, "I'm here to hear what you have to say." However, there was limited prioritization of immediate safety or clarification of the most pressing risk issues. The doctor missed opportunities to directly address acute risk and the impact of medication non-adherence early in the assessment. For example, a more effective approach would have been, "I can hear how distressing these voices are for you. My priority is to keep you safe. Can we talk about any times when felt you couldn't keep yourself or others safe recently?" Assessing historical context and relevance. There was minimal exploration of the patient's psychiatric or psychosocial history. The only historical element enlisted was when the doctor asked for how long these voices are with you, to which the patient replied with some detail. There was no inquiry about previous admissions, treatment adherence, or the course of illness. More comprehensive history taken would have included questions like, "Have you had this experience before? What helped in the past? What did you last feel well? When did you last feel well?" Indication of prescribing issues and details. Presenting issues and details. The doctor did ask for details about the hallucination. How many voices do you hear? Can you hear me now? Inside or outside your head? And about the content of the voices, what type of losses all do you need to do? However, the questions were sometimes unclear or poorly phrased, making it difficult for the patient to respond effectively. The doctor did not systematically elicit the full range of psychotic symptoms or clarify the impact on functioning. Conducting risk and safety assessment. The doctor made some attempts to assess the risk, including, did you try to hurt yourself before? And do you to try to have hurt anybody else? As well as, do you feel like, are you going to add up on these voices? However, these questions were often unclear and lacked follow-up, missing depth in assessing intent, planning, access to means, and protective factors. There was no structured assessment of risk from others or neglect. Evaluating physical health and wider perspectives. There was minimal attention to physical health, except for the patient mentioning, "I don't think I have been eating glass these last few days." The doctor did not follow up this significant disclosure or inquiry about other aspects of physical health, medication, side effects, or general well-being. A better approach would have been, "Eating glass can be very dangerous. How you had any injuries or needed medical attention. Gathering psychological, social, and environmental information. There was no exploration of the patient living situation, support network, employment, or social environment. The patient mentioned, since before I lost my place before I got this flat, indicating social stressors. But the doctor did not pursue this. Questioned who support you at home or how are you managing day to day were absent. Communication. Consultation structure and management. The consultation lacked clear structure with disjoint question and abrupt.
شايفة هنا؟
Yes. The consultation lacked clear structure with disjoint questioning and abrupt topic change. Example include the sequence from "Did you try to hurt yourself before?" to "Do you to try to have heard anybody else?" to "How many voices do you hear?" without summarizing or signposting. There was little evidence of agenda setting or summarizing key points. Consultation style. The consultation style was inconsistent, sometimes apologetic, "I'm sorry, but okay," sometimes dismissive, "No, I'm not gonna bug you again." The doctor attempted reassurance, "You should trust me because I'm here to help you," but this was not always tailored to the patient paranoia and distress. The style did not consistently demonstrate containment or empathy. Attitude and behavior. The doctor's attitude was generally non-confrontational, but at times appeared passive or unresponsive. "Sure, no, I'm sorry, but okay, okay." There was little evidence of active engagement or validation of the patient distress throughout the interaction. Listening skill and responsiveness. There were moments of attempting listening. "I'm here to hear what you have to say." But overall, the doctor struggled to respond meaningfully to the patient disclosure. For example, after the patient revealed eating glass and command hallucinations, the doctor failed to explore these further or offer reassurance. Questioning style. The questioning style was often unclear or confusing the legacy model into that model. And that's and that's and talking my head into that power. What type of losses? All do you need to do? Questions were sometimes poorly structured, making it difficult for the patient to understand or answer effectively. More direct and clear questions would have improved the quality of information gathered. Language use. The doctor's language was sometimes inappropriate or confusing, with several poorly formed questions. The legacy model into that model, and that's talking in my head into that power. At times, the doctor used vague or ambiguous language which did not help establish rapport or understanding. Clear, simple, and empathic language would have been more effective.
اوكي شكرا thank you. زي ما قلنا احنا still we are in a process of training، يعني ما حنتوقع انه everything will be perfect، لكن it's a good trial. حاولتي والفيد ده بيديك الفيدباك والاسسمنت فيدباك بتديكي فكرة عن الحتت اللي انت you need to improve. اوكي دائما ما بنقول نحن دائما يعني الهنتس اوف ذا بيشنس، لما البيشنت يقول لك حاجه ما تمشي تنط في سؤال ثاني، تتابع معه. يعني دي حاجه فيري سيريس، انه قالوا لي ياكل القزاز مش كده، ما وقفت فيها بس فوتها طوالي زي ما قال لي. ف فيري امبورتنت. وفي حاجات هو انت سالت عن harming others، لكن هو ما فهمها عشان الاكسنت بس، يعني حتى زول اللي عمل assessment ما فهمها. ف you did well، ودائما we will improve ان شاء الله. اوكي، شكرا لك، شكرا لك. مهجة عندك كلام؟
لا والله ما في حاجة، لكن بس الحاجة الوحيدة إنه هما تاني حنختارهم بالليستة، يعني ما حيجهزوا
وفي
الكيس
نفس
في
اليوم،
في
نفس
السيم
الكيس.
فلو إن شاء
وحقيقة
الله.
أيوة، يعني حسي اخواننا والله نحن عايزين نتكلم بكل صراحة. لو البرنامج ده يعني ما فيه فايدة او عامل ازعاج للناس نلغيه. والله يعني من احنا we are doing it for your own benefit، ما لينا نحن، ليكم انتوا. فهل يعقل مع يعني زول يخش ويعمل نفسه اونلاين هو ويكون ما في؟ This is not good. This is not good at all والله. يعني نحن we cannot prove it حسي، وما بنقدر نتهم زول. لكن لو اي لحظة من اللحظات اتأكدنا انه someone is cheating، والله ده لا بيشبهنا لا بنشبهه، ولا يمكن يكون سايكايتريست حقيقة. والله هيكون في إجراءات في مجلسنا وفي المجلس الطبي السوداني. ده تشيتنج. الدكتور should never ever cheat. ما عايز يقول أنا ما عايز أو ما حضرت، يعني لو غايب أحسن مما هو يخش أونلاين ويكون ما في. دي حاجة. الحاجة الثانية، يعني نحن تقديرا لظروف الناس، المحاضرة ساعتين، وكلها محاضرات كلينيكال، ما كلام ممل، حاجة كلينيكال ممتعة. في الساعتين ديل لو الزول حضر 40 دقيقة كنا بنحسب له. لكن it seems نحن we have to change this. يعني لو حضر ساعة معناه دي 50% من الوقت. أقل شيء تاني ساعة. لو الزول حضر 59 دقيقة absent، لو حضر 59 دقيقة حقيقة. ف يا سلافة صح، انت قلت مستفيدين، لكن البيهيفير بتاع بعض الناس ما صحيح، يا ما بيدل على كده يا سلافة. البيهيفير ما بيدل على كده. يعني ويا محمد جلال، البرنامج مفيد قلت، لكن انا ما بعمم، يعني التعميم دائما مخل. لكن في واضح انه في ناس ما ناس الشبكه دي ما مشكله يا اخواننا، احنا ما قلنا ناس السودان عارفين الشبكه نعمل لهم شنو. لكن في ناس خارج السودان وفي ناس اونلاين معانا شايفين اسمائهم لما ننده لهم ما موجودين. يعني دي حاجه اكتشفناها الليله، حتى دكتور ياسر يعني استغرب فيها. دي حاجه احنا كنا قايلين اي زول اسمه مكتوب معناه موجود معانا. فمعناها هل نصل لمرحله انه عشوائيا نقول والله يا اسمع علي الطيب انت موجوده ولا ما موجوده؟ ردي. والله يا امام بشير موجود ولا ما موجود؟ يلا ناخذ الاسماء كده. يعني بتكون شيمفول والله لو وصلنا مرحله زي دي. تراست اند كونفيدنس. انا اكون اونست، اصلا اكون اونست، بس ما عايز ما بحضر، خلاص انا غايب عندي ظروفي. لكن ما اخش اونلاين واكون ما موجود حقيقه. ف ياسر والله يتكلم في الموضوع ده، انت يعني زول يعني مشرف على البرنامج ده لك سنتين وشويه، رايك شنو في الظاهره دي؟
هي الظاهرة احنا هنرجع تاني. المرة اللي فاتت تكلمنا زي آخر المحاضرة، لما احنا قاعدين نفتح الزوم ده بنفتحه قبال المحاضرة ب10 دقائق، عشان اي زول عنده ونس اي حاجة زي كده ندي الناس ذاته فرصة عشان تسخن تبتدي الكلام، عشان الساعة 2 نبتدي. الساعة 2 احنا لحد بقى الساعة 2 بدت 36 زول، يعني اقل تقريبا من نص الناس موجودين. نفس القصة دي احنا نبهنا عليها المرة اللي فاتت. يعني الناس اقل شيء انت the minimum انك you have to show interest. ما ممكن الليله النص اكثر من نص الجروب ما موجود. وبعدينك يعني بالحصل ذاته الليله افتكر موفينج فورورد الناس يعني ما في زول يحضر، الناس تكون جاهزه انه ممكن في اي وقت، بالذات للناس اللي ما قدمت ممكن الناس ينادوها.
يس يس. طيب في حاجة ثانية، ما عارف يا يوسف فضل الله، هل
ايوه
وقعوا
يا
على
دكتور، ايوه.
وقعوا على القائمة ولا ما وقعوا عليها؟
في جزء وقع وفي جزء راسلته نصين عشان استعجله للتوقيع. سامعني
يوم
واضح؟ بس
3 يوم.
معلش انا عشان
سامعك
اي
سامعك.
ايوه.
الحكاية دي لها 3 يوم مما هي عندهم عشان يوقعوا، بس عشان نخلص من الدفعة 45، 41 ل 45 نبتدي في دفعة ثانية، عايزين نعمل خصم. طيب انت قلت لي سألت آيات حامد حجازي، دفعتك كم آيات حامد حجازي؟ انت معانا دفعتك كم يا آيات؟ الدفعة كم انت؟